Imagine walking a tightrope where every single step has to perfectly balance two opposing forces. Now imagine that tightrope is your own health, and you're dealing with a chronic illness. That's often the reality for millions globally living with chronic kidney disease, especially when it comes to a really crucial medical decision: anticoagulation. Welcome to the deep dive. Today we're taking a plunge into the incredibly complex world of preventing blood clots in patients with chronic kidney disease, CKD, and end-stage renal disease, ESRD. And this isn't just about medication. It's about navigating a truly delicate, sometimes, well, paradoxical medical landscape. You've shared a stack of vital sources, articles, cutting-edge research, expert reviews, and our mission today is really to cut through all that information overload. We want to pull out the most important insights, give you those aha moments, and hopefully leave you feeling truly well-informed about where things stand now and what's coming next in this critical area. We'll try to uncover why this decision is so challenging, what the current evidence actually tells us, and what innovations are on the horizon. And just so you know, we've pulled from comprehensive reviews like Anticoagulation in Chronic Kidney Disease, Current Status and Future Perspectives, specific analyses on things like DOAC use in end-stage renal disease for VTE treatment, and broader overviews too.
Yeah, and what's truly striking right off the bat is just how pervasive this issue has become. CKD isn't just a niche concern, it's a rapidly escalating global health crisis. I mean, the number of years people live with disability due to CKD has actually risen, get this, 93% since 1990.
No.
A staggering figure.
93%, wow.
Exactly. And for those over 75, it's now a top 10 cause of age-standardized disability. A lot of this rise is, well, it's intimately linked to the increasing prevalence of conditions like diabetes and hypertension worldwide. Clinically speaking, we diagnose kidney disease when the estimated glomerular filtration rate, or eGFR, basically how well your kidneys are filtering waste, falls below 60 millimilli, 1.73 milli2 for 3 months or more. And here's a crucial point. As that GFR falls, the number of other health problems a patient has, their comorbidities, just keeps climbing.
That's a massive increase in burden. It really puts a spotlight on how prevalent this is. So you're describing a situation where, as kidney function declines, people are already grappling with a whole cascade of other health issues. But now, when you layer on the need for anticoagulation, we hit this incredible paradox. These patients face a significantly high risk for both dangerous blood clots and life-threatening bleeds. It almost sounds impossible, doesn't it? How can their bodies be primed for both?
It does sound counterintuitive, absolutely. But the body's physiology in CKD and ESRD creates this unfortunate double-edged sword. Let's first look at why they're so prone to clotting, the prothrombotic factors. Cardiovascular risk, meaning heart attacks, strokes, it dramatically increases as kidney function declines. In fact, it accounts for about half of all deaths in CKD patients.
Half. That's huge.
It is. And dialysis patients, they have the highest incidence, particularly in their first 2 years of treatment. They face a 2 to 3-fold increased risk of venous thromboembolism, VTE, think deep vein clots, and a 2-fold increased risk of pulmonary embolism when clots travel to the lungs. And here's where it gets incredibly challenging. Their risk of atrial fibrillation, AF, that irregular heartbeat leading to stroke risk, is a staggering 10 to 20 times higher than in the general population.
10 to 20 times higher for AF. That's an astonishing jump.
Yeah.
So what's happening biologically that primes their system for clots in such an extreme way?
Well, in ESRD, the body essentially enters the state of chronic inflammation. Think of it like a persistent, low-grade fire burning in the system. This inflammation causes elevated levels of many of the, let's call them sticky proteins in the blood that promote clotting, like fibrinogen, factor VIII, von Willebrand factor, C-reactive protein. At the same time, the body's natural clot busters, things like antithrombin, they get depleted. And on top of that, the lining of their blood vessels, the endothelium, becomes dysfunctional, and their platelets, those tiny cells crucial for clotting, become overactive, sort of hyper-responsive. So you have more of the bad stuff, less of the good stuff, and the whole system is just primed for forming dangerous blockages.
That paints a really clear and frankly concerning picture of the clotting risk. But as you said, they also have this high risk for bleeding. How do these patients simultaneously have so many factors pushing them towards dangerous bleeds? This really highlights that tightrope we talked about at the start.
It's the other side of that very thin tightrope, exactly. Bleeding is reported in up to 50% of CKD patients, 50%. And they face a 5 to 10-fold increase in intracranial bleeding that's bleeding inside the brain. The highest baseline bleeding risk is typically seen with an eGFR less than 30 LM in 1.73 mL2. And for dialysis patients, upper gastrointestinal bloating can be up to 100 times more common than in the general population.
100 times. Goodness.
It's truly multifactorial. Their platelets often don't work properly, maybe impaired activation, reduced levels of crucial signaling substances like ATP or serotonin, defective enzyme activity. Anemia, which is incredibly common in ESRD, also significantly contributes to bleeding risk. You need healthy red blood cells to help platelets get to the vessel wall efficiently. And ironically, even the dialysis process itself can cause mild thrombocytopenia, a lower platelet count. So it's this incredibly delicate and often failing balancing act between these two opposing life-threatening forces.
Okay, let's try to unpack this for one of the most common reasons patients need anticoagulation: atrial fibrillation, AF. The dilemma here in CKD patients really encapsulates this tightrope walk you described. You've got high prevalence, a hugely increased stroke risk, and then this heightened bleeding risk just staring clinicians in the face. Feels like every decision is fraught with danger. So what was the traditional approach here, and what were the main challenges?
For a very long time, warfarin was really the only game in town for oral anticoagulation. It has a long history, sure, but in CKD patients, it comes with significant hurdles. They are just prone to reaching super therapeutic levels. Their blood gets too thin too easily, which is why they often need much lower doses. There are also unique and quite severe complications, things like calciphylaxis, painful skin lesions, tissue death, and anticoagulation-related nephropathy.
Wait, the treatment itself can harm the kidneys further.
Exactly. It can ironically accelerate kidney damage, a real catch-22 for these already vulnerable patients. And critically, those common scoring systems we use to assess bleeding and stroke risk. Has bled, CHATD2 vaxxed.
Yeah. They unfortunately did not include ESRD patients in their big validation trials. So their reliability for this specific high-risk group is, well, it's questionable, much less reliable.
So warfarin sounds like it was often more hazard than help in many cases. What about the newer generation, the direct oral anticoagulants, the DOACs? In the general population, they've been a bit of a game changer, right? But for our CKD patients with kidneys that aren't filtering well, how do these drugs, which often rely on the kidneys for clearance, actually perform? That's the key question, definitely. Because how much a DOAC relies on kidney clearance determines how much it might accumulate if kidney function is impaired. And their renal clearance varies quite a bit. Dabigatran is about 80% cleared by the kidneys, edoxaban around 50%, rivaroxaban 35%, and apixaban down at 27%. But it's crucial to remember, even with lower renal clearance like rivaroxaban and apixaban, plasma levels can still increase significantly in advanced renal impairment. The drug hangs around longer at higher concentrations. There was betrixaban, an anti-zounded DOAC with very low renal clearance, just 11%. It showed some early promise, but unfortunately it was discontinued from the market.
Okay, so some accumulate more than others. What's the evidence tell us about using them in moderate to severe CKD folks not yet on dialysis? Are they still better than warfarin here?
Right, for patients with a creatinine clearance below 60 millinelm, but not yet ESRD. Well, the major DOAC registration studies Aristotle Rockaday, Engage, AFTEMIA 48, RLIY, they did include about 15-20% of participants with CRCL below 50 millinelm. And the key takeaway here, maybe one of those aha moments, comes from a large meta-analysis. Nearly 125,000 AFCKD patients, specifically excluding ESRD.
And what did you find?
It found DOACs were superior to warfarin, both for reducing stroke and thromboembolism risk and for major bleeding risk. And this held true even in severe renal impairment, meaning a CRCL below 30 LMN. Specifically, apixaban and edoxaban seemed most effective for reducing clot risk, and apixaban also had the lowest major bleeding risk in that analysis. So for moderate CKD, yeah, DOACs have really become the clear frontrunner. It's fundamentally shifted the standard of care away from warfarin, offering better protection and fewer bleeding issues.
That sounds incredibly promising for moderate CKD. But now, let's get to the really tough part. Patients with end-stage renal disease CRCL less than 15 are on dialysis. This is where the picture gets far less clear, you said, and the clinical decisions become acutely complex. What are we seeing, or maybe not seeing, in this population?
This is truly the most challenging area, largely because there's a severe lack of robust randomized controlled trials, the gold standard evidence we really need. For warfarin in ESRD, remember that meta-analysis of almost 47,500 patients, it actually showed no significant advantage over not anticoagulating at all.
No advantage.
None. And in fact, it indicated an increased risk of hemorrhagic stroke. Major bleeding happened in about 15% of patients, even without anticoagulation. So warfarin isn't just maybe less effective, it could actively cause harm here.
Okay, so if warfarin is looking pretty bad for ESRD, What about DOACs in this group? You mentioned the lack of definitive trials, so what kind of data do we have and what is suggesting?
Right. Since we lack those gold standard RCTs, we have to rely more heavily on observational data, studies looking at real-world patient outcomes. They offer important signals, but they aren't as definitive, of course. What's promising here is that some studies have suggested apixaban, particularly at the 5 milligram twice-daily dose, was associated with a significantly lower incidence of major hemorrhage compared to warfarin, even compared to dabigatran and rivaroxaban in one meta-analysis. Another large retrospective study, this one over 25,000 ESRD patients, found apixaban significantly lowered major bleeding risk by about 28% without increasing stroke risk compared to warfarin. That study even suggested the 5 milligram twice-daily dose was superior to a reduced dose of apixaban and warfarin for a combined outcome of stroke, systemic embolism, and death.
That observational data for apixaban sounds quite compelling, especially given the poor performance of warfarin. But relying just on observational studies, particularly in such a high-risk group, there are always caveats, right? What are the biggest limitations or counter-arguments? Are there, as you hinted, other studies that paint a less optimistic picture?
Absolutely, and that's a critical point to make. It's definitely not a universally agreed upon solution based only on current data. Some smaller reviews have reported increased bleeding or maybe no difference in stroke rates with apixaban in this ESRD population. That just underscores the need for more definitive studies. It's also really important for you to know. While the FDA has approved apixaban 5 milligrams twice daily for AF in patients on long-term dialysis and rivaroxaban 15 milligrams once daily in ESRD,
Yes?
these recommendations are based on pharmacokinetic and pharmacodynamic data, basically how the drug moves through and acts on the body, not on robust, large-scale clinical trial evidence showing improved outcomes.
Okay, that's a key distinction.
It is, and other DOACs are generally not recommended for this population, so clinicians are often making really complex decisions based on the best available but still quite limited evidence.
Okay, let's shift gears slightly now to venous thromboembolism, VTE, in CKD patients. Are the assessment challenges similar here as with AF, or is the picture any clearer?
The assessment challenges are just as acute, I'd say maybe even more so. Unlike AF, there aren't really any risk assessment scores specifically dedicated to CKD patients for VTE. Existing scores like VTE bleed or RE8, they do consider renal impairment, but they often exclude ESRD patients entirely, or they lack that granular severity grading. You really need to make truly individualized decisions. So clinicians are often flying with, well, less precise instruments to gauge risk for these patients.
Got it. So for those short-term situations where immediate injectable anticoagulation is needed, say, in the hospital for a new clot, what are the main options?
Well, unfractionated heparin, UFH, has traditionally been seen as safer. Its clearance involves the reticuloendothelial system, sort of a broad immune and filter network rather than relying solely on the kidneys. However, its metabolism can still be a bit unpredictable in moderate to severe CKD, but it probably remains the safest bet in ESRD. Low molecular weight heparins, LMWHs, are generally more predictable pharmacokinetically. But the smaller LMWHs, like enoxaparin, they rely heavily on renal clearance.
So the dose adjustments needed.
Definitely. They require reduced doses and careful anti-CISA monitoring, checking the drug level for patients with a CRCL less than 30 ml/min to prevent accumulation. Tinzaparin, which has a higher molecular weight, has some studies suggesting standard doses might be okay in CRCL greater than 20 ml/min, offering maybe a bit more flexibility there.
And what about DOACs for VTE in moderate to severe CKD? Again, for patients not yet on dialysis. Do we have better evidence here compared to ESRD?
Similar story to AF, really. The evidence primarily comes from those major DOAC registration RCTs, which again largely included patients with mild CKD or normal renal function and generally excluded ESRD patients. However, a systematic review did show that DOACs were superior to warfarin regarding bleeding risk, with no significant difference in VTE recurrence, for patients with a CRCL between 30 and 50 ml/min. So this is another area where DOACs are increasingly preferred over warfarin for moderate CKD. But there's still an ongoing need, definitely, for studies that specifically compare different reduced DOAC doses and renal impairment for VTE treatment.
And then back to that most challenging group, ESRD patients needing treatment for VTE. I'm guessing the evidence is even thinner on the ground here.
You're absolutely right. The evidence is extremely sparse. There are no RCTs published specifically for VTE treatment in ESRD. It's a major, major gap. What we have is, again, observational data, often from large databases like the U.S. Renal Data System. These findings have shown that apixaban for acute VTE, both at the 5 milligram twice daily and the lower 2.5 milligram twice daily dose was associated with significantly reduced major bleeding, intracranial hemorrhage, and GI bleeding compared to warfarin.
And VTE recurrence.
No significant difference in VTE recurrence or mortality in those studies. One slightly larger study actually found apixaban superior to warfarin in both major bleeding and VTE recurrence at 6 months.
So again, some very promising observational signals for apixaban suggesting it might be safer, maybe even more effective. But you mentioned conflicting data for AF and ESRD. Is that the case for VTE as well? What should clinicians really be taking away from this limited, sometimes conflicting evidence?
Yes, there are conflicting signals here too. Smaller reviews have reported significant bleeding and recurrent VTE events with apixaban use in ESRD for VTE. So again, it's not a slam dunk based on current data. This means that while apixaban shows promise, the lack of robust RCTs continues to be the biggest hurdle. Every treatment decision has to be a very careful, highly individualized judgment call. Clinicians really have to weigh that specific patient's risks, clot risk versus bleed risk, extremely carefully, acknowledging these significant evidence gaps.
Given all these challenges, these limitations, particularly for ESRD patients where that tightrope is thinnest, it really sounds like we desperately need genuinely new solutions, which leads us perfectly to what's on the horizon, factor XCI or FXI inhibition. Why is this a new approach and why is it generating so much excitement?
It's a truly exciting prospect, absolutely, because the current DOAC choices in ESRD are so limited and bleeding remains such a significant concern, even with the most promising options like apixaban. What's truly fascinating here is the science behind factor X itself. It's a protein that plays a crucial role in amplifying and stabilizing a clot, helping it grow strong and persistent. But here's the potential game changer. People born with a congenital FXI deficiency. They have a mild bleeding disorder, yes, but critically, they are not associated with spontaneous major hemorrhages.
Okay.
And even more interesting, they actually seem to have reduced rates of cardiovascular disease and VTE.
Really?
Yes, so this makes FXI inhibition a highly attractive target. The idea is to maybe prevent pathological clots without completely crippling the body's essential ability to stop bleeding from normal injuries, potentially offering much safer anticoagulation.
That really does sound like a game changer of a concept. If you can prevent the dangerous clots without the same severe risk of bleeding we see with current drugs, that's almost the holy grail for this population, isn't it? So what kinds of FXI inhibitors are being investigated right now?
There are a few different types emerging, and each has potential advantages, especially for CKD patients. We have small molecule inhibitors like BA243-3334 and BMS 986177. These tend to have low renal clearance, maybe only 8–20% cleared by the kidneys. Then there are antisense oligonucleotides like fesomersen. The ARCHI-SCEN study looking at fesomersen has already met its primary endpoint for major or clinically relevant non-major bleeding. That's incredibly encouraging news. We're waiting on the formal results.
That sounds positive.
Very positive. And finally, perhaps most excitingly for CKD patients, there are monoclonal antibodies like osicelamab and abelacimab. These have no renal clearance at all.
None at all.
None. Which is a massive potential breakthrough because it means their metabolism shouldn't be impacted by declining kidney function, making them exceptionally promising for patients with even the most severe kidney disease. Early trials have shown them to be either equal to or maybe even more effective than enoxaparin for VTE prophylaxis after surgery, and osicelamab specifically showed lower bleeding rates in one study.
No renal clearance at all. That truly could be the breakthrough this population desperately needs. What's next for these therapies? When might we expect more definitive answers?
Well, there are crucial ongoing studies like EMERALD and CONVERT, which are specifically enrolling hemodialysis patients. That's key. We are eagerly awaiting their results to determine if FXI inhibition will finally offer that safer, more effective solution for anticoagulation in this very vulnerable population. It's a very active and, I think, incredibly hopeful area of research right now. It could genuinely redefine safety for millions.
So we've walked that precarious tightrope today, haven't we? We've seen how chronic kidney disease creates this truly unique challenge. Patients face both heightened risks of life-threatening clots and dangerous bleeding, making every treatment decision incredibly high stakes. For mild to moderate CKD, especially for AF, the evidence for DOACs seems fairly conclusive now, showing clear benefits over warfarin. However, for end-stage renal disease, there remains a significant, undeniable, unmet need for robust, definitive evidence.
Indeed. And specifically regarding DOAC use in end-stage renal disease for VTE treatment, the current consensus, based on the sources you provided, is that DOACs cannot be broadly recommended over warfarin at this time. Anticoagulation decisions must be highly individualized, carefully weighing both thrombotic and bleeding risks for each specific patient. If DOACs are considered, it's generally apixaban, often at that lower 2.5 milligrams twice daily dose for VTE, or rivaroxaban at 10 milligrams daily, as those are the most studied regimens in dialysis patients. But, and this is crucial to remember, these specific regimens are not FDA approved for VTE treatment and ESRD. They are considered off-label use.
Right, that off-label point is critical.
Absolutely. And it just highlights precisely why further prospective studies, those RCTs, are so desperately needed to firmly establish their safety and efficacy in this vulnerable population.
What's truly fascinating here, though, and perhaps our most hopeful takeaway, is that rapid advancement we just discussed in factor XI inhibition. Imagine a future where we could offer effective anticoagulation with a significantly lower bleeding risk, especially for those most vulnerable with ESRD. This isn't just about a new drug, it's about potentially redefining safety and quality of life for millions. So as we look ahead, what aspects of this delicate balance managing clots versus preventing bleeds do you think future research will tip most dramatically in favor of patient well-being?